multiple sclerosis symptom onset tends to be in one's 20s and 30s, and that women are more commonly affected with MS than men. Given these, family planning is an important consideration to think about in the care of people with MS. Historical studies of women who were either untreated or on low-efficacy disease-modifying therapies show that disease activity tended to fall during the pregnancy period, followed by an increase in the early postpartum period. However, recent studies have also shown that women who either have more active MS or are treated with modern and high-efficacy treatments such as Natalizumab or fingolimod may be at elevated risk for disease activity during and after pregnancy, particularly after these therapies have been stopped. Therefore, it is important to investigate how newer disease-modifying therapies such as Ocrelizumab may interact with MS disease activity in the context of pregnancy in order to best guide our counselling and treatment strategies. We use data from the MS-based international registry to investigate disease activity during and after pregnancy in women with MS who use either Ocrelizumab or other disease-modifying therapies before conception. We were able to include 1,985 term and preterm pregnancies from 1,722 women. This included 73 pregnancies from women who used Ocrelizumab pre-conception. In this group, we observed no relapses in pregnancy, and only 3 women, or 4%, experienced 1 relapse each in the 6-month postpartum period. For Natalizumab, we looked at 2 strategies. Women who continued Natalizumab into the 3rd trimester and then restarted Natalizumab within 1 month of delivery had low relapse rates both within and after pregnancy, with approximately 5% of women relapsing in the postpartum period. Whereas women who stopped Natalizumab before 1 month of pregnancy and then restarted treatment more than a month after delivery had increased relapse activity through pregnancy, followed by a spike in relapse activity after delivery, with 31% of these women experiencing a postpartum relapse. We also observed that postpartum relapse rates were lower in our Ocrelizumab group than in our dimethyl fumarate and low efficacy DMT groups. Our findings support the planned use of Ocrelizumab preconception as an effective option to control disease activity in the peri-pregnancy period. I think that strategies for disease-modifying therapy use, which are compatible with conception, should be discussed and considered early on after one's diagnosis with multiple sclerosis. The joint decision-making approach between neurologists and women with MS remains important to help select the best option for each person. Data on preconception Ocrelizumab use and pregnancy and infant outcomes has so far been reassuring, but there are currently ongoing studies which aim to investigate these further. These findings will be important to guide counselling and also joint decision-making. There are other disease-modifying therapies which are recently available, such as cladribine and ofatumumab, and so data around their use and peri-pregnancy disease activity will also be useful to help inform the choice of a disease-modifying strategy for family planning.